provider.
Part of our.
This is not part. This is actually not technically part of the opioid REMS work. That's part of this program. But I think as a sidebar, while we're waiting for the audience to accumulate, I think I would look both to Dr. Stevens and Dr. Sullivan. It seems to me that much of what our opiate prescribing is managing PTSD. And I wonder if perhaps this ought to be part of a future opiate REMS conversation. But this is not actually part of that. And Kara was describing to me our upcoming schedule, which will have beginning right after Labor Day, extending to right before Thanksgiving will be a repeat for those of you who may have missed it, and for those either a section of it or all of it to join us in the COPE REMS sequence, which will have you fully complete on the educational modules, and then ideally, and I would strongly encourage taking the completion exam and be a REMS completer for that. But I'm quite certain there'll be no PTSD questions on that, as we understand it's not part of the question that the REMS curriculum has. But I want to introduce Dr. Stevens. Dr. Stevens has been one of our key. That's fine. That's perfect. There, it really picks up well.
Okay.
Yeah. No. One of our key providers at the Center for Pain Relief. She's special expertise in PTSD and cognitive behavioral therapy, and as far as I'm concerned, present company excluded, we couldn't manage without her. So thanks for joining us here today.
Thank you. David asks me to come every 6 months or so to give another update on PTSD to you all, some of which I try to make more general and practical, to just give you a refresher on what PTSD is, how it works, and a bit of how it overlaps with pain, and just kind of the state of the art of what we know best in treatment out there. So hopefully you'll walk away with a couple of practical tips and knowledge from this. And some of this you hopefully should sound familiar. Sorry. So we got a little bit of an echo here. Okay, so the first thing I always like to start off with when we think about post-traumatic stress disorder is what is a traumatic event that actually has to qualify you to have PTSD. So it's been flexed a little bit in the new DSM-5 in terms of really emphasizing that you can actually only just witness a really horrific event. You don't have to experience it directly yourself. So, for example, if you see a child hit by a car right in front of you, that can be a traumatic experience, even though it wasn't you that got hit. Actual or threatened death, serious injury, sexual violence, all of these things qualify. PTSD. The other thing you want to look for a true PTSD disorder is that there is more than a month of significant distress or impairment going on in the various symptoms that meet criteria. So just to lay out what the different criteria are for PTSD, we start with the fact that you have to be re-experiencing the trauma in some kind of haunting way. And usually that's either intrusive memories or nightmares, flashbacks where someone might feel like they're actually living through that trauma again, or physiological reactivity. So in other words, your body is massively reacting to some kind of reminder, or you're having intense psychological distress at the reminder. So you have to have at least one of these criteria. You have to then be avoiding it in some way, and you only need one of these as well. So you need to be avoiding either the memories, the thoughts, or the feelings that are coming up, or avoiding some kind of outside trigger that's coming at you, some kind of reminder. Hyperarousal was also part of the old criteria here, where you need two of these, which include having increased irritability or anger outbursts. That's often what you would see clinically in primary care, where you might see that kind of come out of nowhere from patients. Also, reckless or self-destructive behavior has been added to the criteria now. Hypervigilance we're used to seeing, startle, poor concentration, which overlaps with depression, of course, and then sleep difficulties. Usually that's the nightmares coming up. Mood and cognitions was a new category kind of separated out, where they took some of the old criteria and added in a few of the new criteria based on more recent research. And what that looks like is you need two of those criteria. You need to have some kind of memory loss, either that's unexplainable by some kind of TBI. So in other words, you went through this trauma and there are just parts you blanked out in. You might have kind of pervasive negative beliefs or negative self-blame about yourself. We might see this in pain as well, where you see people blaming themselves for their chronic conditions and saying, it's my fault, it's because I let myself get out of shape, etc. You'll see this kind of pervasive self-blaming. Everything is my fault. I'm failing my family. I can't believe the burden I've become. Negative emotions are also a potential criteria here. Anhedonia, just like in depression. Detachment from other people, where people might feel like they might have loved ones around them, but this is really kind of a different feel for them, where they feel like even though there are people around, they can't feel like they can connect with those people the same way they used to before the trauma. And then any kind of lack of positive emotions also can meet criteria. So there's several in here that are quite different from the old DSM-4. Does trauma always cause PTSD? A lot of people think, well, if you've got some horrible trauma, we might make the misnomer that they've got post-traumatic stress disorder. But you see all those criteria. The reality is it's actually the very small minority of people who develop PTSD. So when we've done large population-based studies, 70 to 90% of people, depending on how we survey them just anonymously by phone, for example, will report some criterion A trauma event in their life. So most of us experience trauma. The vast majority of us do. And most of us recover from it resiliently. There is a small percentage of people, and if you look at the NCSR study, the lifetime prevalence is about 6.8% of all adults. So it's actually a very small minority of people that develop full-blown PTSD. We do know that for some reason there's a much higher risk factor for women. There are several other risk factors for PTSD that include substance abuse, sexual trauma, violent trauma, multiple trauma, so the burden of trauma being higher, intense pain after trauma, physical pain, so if you had an intense injury and experience intense pain after, all of these things can set you up to be at higher risk for PTSD. But we still scientifically really don't understand why certain brains develop PTSD and certain brains don't. We know, amongst the vets, I know some of you are with the VA, you probably know these data better than I do, that the prevalence is much higher for our soldiers. And as the wars have progressed over time, the exposure rate to trauma has also increased. So we're seeing much higher, again, it's that burden of trauma. We're seeing higher amounts of PTSD in our more recent vets as well. In terms of chronic pain, depending on how you slice and dice the different studies, there's a huge overlap. 35 to 50% of patients who have PTSD also report they suffer with chronic pain. So let's talk a little bit about how they overlap. In the NCSR study, there's a 7 to 8% overlap as well between just if you look at who crosses with PTSD and pain. We do know to some degree there are higher rates among ethnic minorities, so there might be some disparities there, in terms of having more chronic pain and PTSD crossed together. I just saw a recent study come out of the VA actually where there was some disparities in care among the vets for those that were ethnic minorities as well, and not explained by pre-existing baseline kind of measures or by pathways into care. So for some reason, we still don't fully understand there are disparities in care as well. If you look at a PTSD cohort and ask how many of them have pain, you'll see 20 to 80%, depending again on which populations you're looking at. And the different studies varied. We're looking at traumatized hospital populations versus primary care populations. They varied, but it's pretty high overlap, even if it was just 20%. If you look at pain cohorts, people who report chronic pain, and you ask them how many of you have PTSD, you'll get anywhere from 70 to 50%. And again, it's because, depending on which slice of the population you take. So these are things that really come hand in hand that you want to be thinking about when you've got somebody in there with chronic pain. We also know the higher the pain and the more affective distress and the more disability there is with the patient, the higher likelihood they have PTSD. And we're starting to understand that there are some neurobiological overlaps that we're starting to explore. There are different ways, and I'm not going to say a whole lot more about that, but it is exciting to know that there might be potentially some ways that we can activate different pathways neurobiologically that might actually help both as we move forward. And David probably can speak better to that than I. Negative beliefs about the self, we also know actually mediate pain interference. So you remember we said negative beliefs about the self, that self-blaming kind of piece is a huge piece of PTSD. So if we can treat that piece, we can actually help stop the stumbling block with pain interference as well with patients. The good news in all this is, given that the two are stuck together, is they also tend to get worse together, but they also tend to get better together. Okay, so if we can help people with chronic pain, their PTSD tends to improve, and vice versa. And this has been shown in several different arenas. A lot of these are in collaborative care kinds of environments and multidisciplinary environments where they're treating these things together. Okay, so what can you do as a PCP? Kind of jumping ahead. That was my background, so let's kind of talk forward, practical tips of what you guys can do. So the first thing I recommend is screening for it. Okay, if you've got somebody who's coming in with chronic pain, if you've got somebody who's been exposed to trauma, who maybe doesn't have chronic pain, I want you to know there is this great screener for PTSD. This was developed out of the VA. It was validated very well. There's very high concordance with an actual diagnosis of PTSD using our gold standard techniques. If a person scores 3 or 4 out of 4 on this quick questionnaire, it's 4 items. They simply say yes or no. We give this in our clinic to the patients on paper, so the providers don't even have to do it. So this helps a lot of times our fellows recognize there might be a referral for PTSD. The other thing I recommend as a practical tip, if you've got somebody that you're working with who has PTSD, measure the PTSD symptoms. There are some great screeners for that, much like you guys, many of you are using the PHQ-9 or some other related depression measure to treat depression. This is your blood test for PTSD. There's a great screening tool called the PCL. The PTSD checklist is what the PCL stands for. There's a new version 5 that actually maps onto the DSM-5 criteria. The older one is fine as well, the PCL-C, which is the PTSD checklist for civilians. These were developed out of the VA again and are fantastic. And you can watch these scores, get a baseline if you're prescribing medications to treat core symptoms, looking to see if any of those measurements reduce. The other thing we do is always measure chronic pain interference, and not necessarily chronic pain itself, but how much is the chronic pain interfering in their life. So I'm sure you hear this group talk a lot about, measure things as you go so that you can step up care as needed, because often just doing that patient interview isn't enough information for us to go on, but having them give us a regular rating over time, it can be really helpful. So, there's the step care approach has become very popular in PTSD because it's so hard to get to a trauma-focused therapist who's got evidence-based training potentially. There are a lot of things along the way we can do from a population level to treat all of our patients that might be suffering with PTSD. So in this step care approach, the things I want to emphasize for you guys as PCPs in this is really look at those first few steps or where you're going to be most interacting. And the first is really around engagement, which is very difficult with a lot of these patients. They've got a lot of trust issues. They've got a lot of blaming they might be doing themselves and then to you as well. Those anger outbursts and things. So spending a little extra time to really get that engagement going with these patients who've been traumatized can go a long way. And doing assessment as you go, of course, and trying to figure out, does this person really have PTSD? If they're scoring positive on that screener and they've got 3 or 4 out of 4 on there, you can give them a PCL questionnaire that's got 17 items on it that map right to the DSM criteria, and look to see what the score is on there and whether or not they seem really symptomatic. You can also start medications, right, that can start to treat some of the core symptoms. If they've got sleep issues with nightmares, a lot of times, a lot of my colleagues use prazosin, which I've seen have great benefit for a lot of patients. You can also use SSRIs to treat some of these core symptoms, which often can help people sort of pull things together enough to engage some of these more intense behavioral interventions that they need to get into to get kind of maximum benefit. Then there's a couple of brief behavioral interventions I'll talk about really quickly that you might want to try as well as a PCP. And then obviously there's kind of the all the way stepped up to the psychotherapy, which Institute of Medicine did a nice big review, and everyone kind of agrees at this point is the best treatment for PTSD that we can put together at this point. All right, so a little bit on psychopharmacology of PTSD. This was sort of a great conceptualization. One of my psychiatry colleagues, Wayne Bentham, and I talked about where you sort of think about the core symptoms and treating them first, and then sort of moving out along the lines of what kind of medications you can use. These guys are great. Mark is here, Dr. Sullivan, who is a great resource for how to potentially alter some of those medications, as well as Dr. Taubin. who are here today. Also, one thing that I say as a behaviorist is, when I'm talking to folks that prescribe, is when you're thinking about using benzodiazepines for patients, or they might come to you on benzodiazepines, is to think about scheduling them with anybody with anxiety, whether it's PTSD or any other form of anxiety. Scheduling them is a massively helpful thing, because behaviorally, what our patients will tend to do is take them in response to feeling anxious. And when they do that, they feel a little better after feeling anxious. And what that does is actually reinforce the anxiety, where anxiety, by definition, is a fear response we have to something that isn't actually dangerous. Okay, so we don't want to reinforce anxiety, and if people can take them scheduled, so in other words, if they can anticipate they're going to get anxious in a certain situation, so they take it ahead of time, that's much better behaviorally than if they take it after they've already become anxious. I also see my colleagues use a lot of long-acting benzodiazepines, which tend to not have that kind of immediate hit of a reduction in anxiety, which also can kind of help reduce the risk of that kind of iatrogenic effect. All right, and then measuring along the way, of course, when you start these medications, I think I try to do this with them as well, is figuring out whether or not the medications are working well, and having patients understand, that they can measure it too. And I'll talk at the end. There's a couple of apps. There's an app for that. Patients can use these apps themselves even and measure their symptoms these days. One of the things I wanted to do is just give you a quick exposure to what we talk about in cognitive behavior therapy around anxiety, because you guys are often the ones referring people into this treatment, and I like to sort of pull the curtain aside to see the wizard so that you have a little bit more you can talk about of what we do. And so one of the things we try to do is educate patients around the 3 B's of anxiety, which is about the fact that the body gets anxious physically, physiologically. It's a fear response. Adrenaline's pushing through the body, stress hormones pushing through the body. The brain then also experiences anxiety with thoughts and the different things that our brain starts thinking about. I got to get out of here. I can't handle this. I can't possibly give this talk. They're all going to laugh at me. Whatever the thought might be that we're having, the brain kind of goes rampant. And then we have behavior that clicks in where we really want to safety seek. Let me talk a little faster and get through this talk. No, let me slow down my talking, right, and figure this out. So there's safety seeking that our patients are doing constantly, and some of that anger outburst is a safety seeking behavior they're doing in response to the anxiety. So what we do is we try to treat these things behaviorally, and with the body we try to teach people anxiety management strategies for how to bring those physiological symptoms down that can actually help spiral and trigger the brain and the behavior. We try to help people with cognitive training of how do you challenge some of those irrational thoughts we might be having of, there's no way I'm going to survive here. I'm so behind on my charting. I got to get my charting done, right? And so we have to, sort of soothe ourselves and say, no, it's all right. I know Dr. Taubman's behind on his too, so it's okay that I'm behind on mine. And sort of challenge those more rationally, right? And on the behavior side, what we have to do is help patients see what some of that safety seeking is about, and actually stay in those situations so that their brains can learn that they don't have to run from them. And that's really where exposure comes in. And that's the part where we talk about treatment of anxiety, because that actually starts to extinguish, I should say, those triggers of anxiety. Versus the other strategies on the left, including medications, are management strategies. They don't treat the underlying anxiety per se, but they help people live with anxiety better. But on the right side is the exposure piece of it, where we really want to help people stop having the anxiety initially. Okay. One of the things you guys can do is start to recognize dissociation in patients. This is not a real obvious thing. You're not going to see them roll their eyes back in their head when they're sitting there, in an office meeting with you. But they kind of check out, and they can recognize this, and they don't know what dissociation is. Most of them, they've never heard of that before. So you can educate them about dissociation being a natural part of PTSD, especially, particularly people who have had childhood abuse, childhood sexual abuse, who might suffer from PTSD, have that very ingrained learning that you just kind of leave yourself for a bit. And so you might be talking to them, and they might be sort of distancing themselves from you. And you may notice it, and you may not. So it's actually really worthwhile to ask them, do you ever notice you sort of are outside of yourself a bit when you're sitting there having a conversation? And they can recognize that. This is a problem physiologically because it actually shuts down your immune functioning. And so I think as PCPs, you guys can talk about this as being a very physical illness worth treating for them if they're having issues around wanting to deal with that and saying that's a mental health thing, I don't want to deal with that. You can talk to them about the physical harm it's doing to their body to have that dissociation going on. It's also dysfunctional for the patient, right? It's dangerous because they're checking out. They might not be hearing all the instructions you're giving them for what they need to do and taking medications safely, for example. But they also, in their families and their loved ones, they're disconnecting. They're not there and present in their lives. And so there's all kinds of cascading issues this dissociation causes. One of the basic things we can do is teach people how to ground themselves when they dissociate. So first they have to recognize when they're doing it, and then second, what they have to do is bring themselves back into their body, and it's pretty easy to do that. You can do that just through your 5 senses. So if you teach a patient and say, if you feel like you're leaving yourself for a minute, name 5 things that you see, okay? Or name 5 things that you're hearing, or 5 things that you feel on your body, which sometimes can be hard with patients in pain because then they might focus on the pain. But you want to get them in touch with those 5 senses, and that inevitably leads them right back in, and they're not sort of distancing themselves anymore from their bodies. So this is sometimes a skill we teach people who have a lot of dissociation going on, even before we get to the meat of doing the PTSD treatment and psychotherapy. And this is something you can do in just a couple of minutes when you're meeting with patients. Another thing you guys can think about using is behavioral activation. I know in our family medicine residency program we're starting to teach the family medicine docs, so I don't know if any of you have been exposed to this before in your training, but it's something that you can encourage patients to do right away, right? So if you notice that they're getting less and less engaged in their lives, the idea here is that they might be avoiding certain things. If they've got PTSD, well, I don't want to go out in those social situations because I get really panicky and I freak out, and then everybody, reacts oddly to me. But on the other hand, it's really limiting their functionality, right, to do all that avoidance. So behavioral activation actually targets avoidance, and the problem that we all face with this is we often give what I call the Mount Everest homework to the patient. We say, well, why don't you just go out and kind of walk out to your mailbox? And it seems really easy to me, and it might seem really easy to patients even trying to tell you, oh, no, that's easy. But often it's not. And so sometimes what they might need to be able to do is just start to approach that object. We had a patient who had a bad car accident, and she couldn't even fathom. She had completely confined herself to the house because she couldn't even look at a car without having a flashback to the accident. And so we had to start, very simply and say, okay, well, let's think about having the word car on a piece of paper in front of you. Let's start looking at a picture of a car. Now, can you sit in your house and look at your car just parked in the driveway for 5 minutes? And you let your anxiety go up and then come down. Don't walk away from it. And so thinking about these small pieces of behavior that you can have people start to do, and nothing is too small, because there's nothing worse to a patient than feeling like a failure when you're self-blaming already over everything, and your PCP says go for a walk around the block, and you just absolutely couldn't do it, and you come back in, and you care about that doctor, and you know they care about you, and you tell them I couldn't do it. So having that forgiveness, that sort of non-punishing environment is so important with engagement, and telling that patient, that's okay. Let's break it down. What feels more doable? Let's back it up. What if you were able to just do a tiny bit at home? Or what if you were able to just spend 5 minutes thinking about doing it? Do you think you could start to do that? Okay. So it's about giving them permission to really break things down into small, doable pieces. A tip about, I put in 2 quick case examples that are pretty common that you might see in primary care, and just a couple of really concrete tips that I think all of you are more than capable of doing. And part of this is me sort of wanting to encourage giving you guys permission to do something as small as this tip that I'm going to give you for this patient, because it can go a long way. So this is a 54-year-old mixed-race male patient who had a history of domestic violence as the victim of domestic violence and sexual abuse as a kid. And he came in, I measured him on the PCL, and a measurement over 60 is in the severe category. 45 to 60 is in that mild category. Under 35 is pretty much non-symptomatic at all. So he's pretty severe up at a 69. He had a history of post-surgical left sciatica, a lot of numbness kind of going down into his feet. He was on nortriptyline. He was very against medications, didn't want to take more medication in general, which is why he had such a small med list. And he also had erratic attendance in clinic. I'm sure you all have seen that, where the people kind of show, or they cancel, or they no-show, or they come in and sort of distressed. And he was getting very angry, and the providers in our clinic felt like, there was no provocation there. They were coming in, they were having a good day. They said, how are you? And this patient was getting very, very angry at them. So, the tip I have about this is if you're sensing that you've got a patient that really is coming at you, and you have that good sense that you have not done anything in that situation to provoke that patient, be thinking about PTSD, because that wasn't something that our providers necessarily noticed right away with this patient. I know he had a 69 because I wound up seeing this guy down the road, right? But his providers that he was getting very irate at didn't know that. And so if you notice that happening, think about engagement. Think about how to reflect back to that patient. You seem very, very angry. You seem like, I'm not listening. I think it seems like you feel like I'm not listening at all to you, right? You can use these exaggerated reflections that often can draw people out more into a kind of a pro-social frame. Well, it's not that you're not listening at all. It's just that, you know, what I'm here to talk about is the numbness in my hand, not my feet. You keep talking about my feet. And so it can kind of invite them to tell you a bit more about this, right? So listening an extra few minutes and saying, you know, I really want you to come back and talk to me more about what's going on with you. It's about trust building. And so in that stepped care approach, that's very therapeutic. And just because you haven't, you know, given them something to do at the tail end of that, you're building that engagement, which is incredibly foundational for doing any kind of substantial care with someone with major trust issues. Okay. We had the patient, you know, where they're always coming in and saying, no, I'm fine, everything's great, but they never seem to be getting better, right? And so there's just always something that's in the way. And this oftentimes you'll see with people who have this remote history of trauma, you know, where it was really more in childhood. And so we had a 60-year-old Caucasian woman who had childhood abuse. When we finally measured her on the PCL, she was actually above a 60, which was fairly shocking because she just came in with this, you know, either sort of flat affect or sort of a very smiley, you know, pro-social, hi, how are you? Oh, everything's fine. But in reality, her life was not going fine. She had a long-standing history of back pain with a discectomy in the past. She was on hydrocodone, she was on bupropion, she was on duloxetine. You know, we're going, why is she just kind of not getting better? You know, and she sort of had this presentation where, you know, at one point she just have a big stressor, but the stressor just seemed, her reaction to it seemed much bigger than what the stressor seemed to be. And then the next time she come in, oh, everything's fine and great. And so what we did is then screened her for PTSD and figured out she was actually dealing very severely with post-traumatic stress disorder. She was in a functional marriage, so it was hard to tell, and she was still working. That this was really going on. So you want to think about avoidance. What is she trying to avoid? Because anything she goes near is going to trigger all of that intense distress for her, and she doesn't want to talk about it. So you want to look for this kind of issue, and if you can use that screener and help that patient gain some awareness and say, you know, you're really suffering from a mental health disorder that we actually can treat. You know, are you open to that in doing that? And so, you know, great story. We wound up treating her, and her PTSD went way, way down, and she started to get better. And like I said earlier, pain, PTSD get better together, and that happened for her. All right, best evidence-based treatment for PTSD these days. I'm going to talk about sort of two arenas. There's cognitive behavior therapies out there, you know, that really have been pinpointed as the best evidence-based for PTSD. They're two kinds of psychotherapies. They're both cognitive behavior therapies. They're manualized treatments, so that's why they've got a name to them. And one is prolonged exposure, or what we in the field call PE, and it was developed by Edna Foa. And then there's another psychotherapy treatment called cognitive processing therapy that was developed by Patty Resick. Both of these treatments are about 12 sessions long. Prolonged exposure goes more into strict exposure of whatever the index trauma might be and kind of repeating that exposure over time until their distress goes down. Cognitive processing therapy has an exposure piece to it where they expose to a narrative around whatever their index trauma is. But mainly it's teaching a skill over time for how to deal with what we call stuck thoughts, or thoughts that are destructive for us, thoughts that are tied back to trauma. Our belief system gets very altered when we experience trauma. Sometimes folks, you know, those of us who might do both of these treatments offer patients an option of which one they might want to do. We don't really understand terribly well yet which patients should get which kind of therapy. Both of them are very efficacious. And if people stay in treatment, almost always get better. There's dropout rates, right? So that's kind of the mix of this, is that a lot of people tend to stop treatment, which is difficult. But the active component in these treatments and EMDR, which I'll talk about in a sec, are really exposure. You know, and again, it goes back to those 3 Bs, right? We need to stop all those behaviors that are that safety seeking and help people stay in the moment. And sometimes it's exposure to the trauma memory itself. Sometimes it's the exposure to the thoughts that they're really disturbed by. And sometimes it's facing those avoidant behaviors and needing to learn how to change those patterns. So there are brief versions of these treatments being tried now. They're what we call early responders in many of the studies, and we're finding that those early responders actually hold as long as the folks that finish all 12 sessions. So we're not really good yet at figuring out how to stop treating patients when they should be stopped. And a lot of times patients know that, and I've had that happen to me where they've responded, they're doing well, and then they just kind of quit coming to see me. And I tell folks, the providers ask me in the clinic, do you want them to come back and see you? And I say, they're doing fine. I think it's fine if they stop. EMDR, is eye movement based treatment, is something that's become very prolific, and it's got a lot of training centers out there and licensing behind it, and it's something that a lot of private practice therapists mainly is where you see a lot of this being delivered. Use, and they can get great certification in it. They can advertise about it and say they're a trauma therapist because they do EMDR. It is manualized, and for those therapists that do it in a manualized way, it's got a decent evidence base for it. It's not quite as strong as some of the CBT therapies, depending on how you look at the literature, but we do know that it's a lot easier in the communities to find EMDR therapists. I've had patients that I've treated with a CBT therapy who have had EMDR in the past and benefited from both. So, I think that that's not to say it's a one-size-fits-all, but when you're looking and scrambling for resources, I think EMDR is a good one to go to if you can find it. There is some evidence starting to grow about it as well, that it might have a kind of a sweet spot with people who have intense hyperarousal-based symptoms, because it does expose you, when you're doing the eye movement piece, you're exposing to really intense emotions, which is asking that hyperarousal system to come to the forefront and do that exposure. So they don't do exposure to actual trauma like the other therapies do. They do exposure really to those intense emotions. And the other piece is that's often a little bit of a shorter treatment, so that's the other nice thing about EMDR. Cautions for psychotherapy for PTSD. Things to keep in mind when you're referring people. There are some iatrogenic dangers you want to think about, okay? So if you're doing exposure with no coping or avoidance prevention going on, and so the worst case scenario for me is if I get a patient, I start doing exposure, and then they blow out of treatment, right? Now I've made them worse instead of better. There are psychotherapies where people ask you to talk about your childhood, go back to the past, kind of regress into that. Even some folks that still talk about repressed memory in psychotherapies, those are not good for trauma. There's no good evidence base that repressed memories are real. So our memories are very, very fallible. And so asking people to kind of regress back in and to remember that trauma is not a good thing for people. Requirements you want to think about just as a minimum bar when you have people referring in is, they need to be able to attend the sessions for the treatment, right? So keep in mind, it's going to be probably at least 6 to 12 sessions, depending on where they get into. They need to have some support for that, because a lot of times people, when they enter into this treatment, can get a little worse before they get better, because they're not avoiding anymore. They're going to start facing some stuff. It's going to stir that up. So those first few sessions can be hard. So if they're out on their own, or they're a single mom dealing with kids and they need to keep it together, thinking strategically about how they're going to get that extra support is going to be important. Obviously, you need to get a trained provider who's available in your community and figuring out where you can send them. And mental status, is important to some degree, although I would also let you know that I treat people who are using marijuana every day. I've treated people with traumatic brain injury. The main issue is they need to be able to lay down new memory for this treatment to really work. But if they've got different deficits going on, it just may take a little longer, but it's still a doable thing. So don't be too conservative on your mental status piece. All right, I told you there was apps for that, right? So the VA's actually been putting out a few of these. The biggest one I'd recommend for you guys to talk to patients about, if you feel comfortable talking about this sort of thing, is the PTSD Coach, because it's an app that's built just for patients. You go in and it actually gives you some of these management strategies, walks you through how to do it. It has the PCL embedded in it, so you can use it as a clinical tool as well and have people just answer it on their phone and then share with you what the score is potentially. And then there's a couple of apps as well that are actually assisting the therapist in delivering the CPT therapy and the PE therapy that I just talked about. And then finally, there are some resources. So I think the slides have gone around to you guys as well. You're welcome to check these out. So,
Great. Thank you, Kari. Very informative. I've heard you give this talk a couple times, and I continue to learn from it. The two cases that she presented, I was completely stumped on both and knew a little bit about the patients, but this is the advantage of having someone who really understands the matter. Subsequently, we now, in the pain clinic, on our intake questionnaire, we do a PTSD screen on every single patient when they come in based on its remarkably high prevalence, at least in the population that we're seeing.